So this is your chance to ask questions of Dr. Newman that maybe you didn't get a chance while everybody else had the chance to ask her questions. So please ask away, and then we'll roll into our closing session, and then we'll be done. And so I'm going to be the first.
And I think hopefully you've noticed I don't have all the answers, okay? So be nice. Yes?
So, Dr. Newman, first, thanks for taking care of our son. So here's you deserve at least one outrageously crazy off-the-wall question, so here it is.
Go for it.
So the world, you know, I used to work at a place where every 6 months, what happened? Hello? Somebody cut me off. No.
Yep, you're back.
We back?
Yep.
So there are things called supercomputers in the world, right? And they can simulate all kinds of things. And they get more powerful every 3 months, every 6 months. Has anybody ever thought of trying to simulate some of the things going on in the mitochondria from the standpoint of triggers and things like that? And like I say, maybe it's not possible, maybe it's way too complex. But who knows?
Yeah, I don't know the answer to that question, I'm afraid.
But you know, maybe that's something somebody can consider.
Yeah. My daughter's a math major in college, and that's the kind of thing that she wants to do, and so maybe I'll set her on it. Yes?
My daughter has Elhan, and I was wondering, with tremendous advancement in stem cell research, in fact, adult stem cell research, I know they're substituting and regenerating cells through that process. Is there any research you know of and practicality of doing that in this disease?
So I could give you a very, very long answer, but I know there are other questions, so I'm going to make it short and not to be unfeeling or not explaining myself too well. Stem cell research for optic nerve diseases in general is not ready for prime time. And you can do medical tourism, and people unfortunately do who are desperate, including medical tourism in our own country. If you've looked at the New England Journal of Medicine, there's a clinic in Florida who blinded 2 patients with injecting stem cells, in this case for retinal diseases, but we are not anywhere near where we would have to be to get the exquisite return. Remember, optic nerve do not regenerate. And so, and it's 1.1 million wires that have to go exquisitely to 1.1 million different receptors to get that information back. So do I hope someday, somehow? Yes. Do I think that's going to be the magic bullet for labors? No, I don't believe so. I think the next step will be getting people who have no vision at all from optic neuropathies to maybe be able to see light and shadows and edges of things on the basis of stem cell research. That would be the first step. I think you all are in a better place than that, and therefore, ironically, you need something different. Yeah. Yes, sir.
Yes, hello. I had 2 quick questions. One was gene therapy and stem cells. I need to know the difference of them.
Sure.
From time to time, when you got a business, you don't get the chance to check things out all the
Yeah.
time. When you get time, you check in, you find out, you come back to it.
Sure.
So that's the first question. Secondly, when you look for clinicaltrials.gov, you see a lot of companies now a lot more companies who are a part of it now than it was maybe 5 years ago. But are they FDA approved?
Yeah.
And are they
These
really,
are
are companies really good?
Right.
Really
Very,
good
very good questions, and it dovetails very well, sir, with your question. So stem cells therapy is the idea that you can inject or deliver some way a cell that still has the capability of differentiating into the type of neuron that you want it to, you need the computer, type of neuron that you want it to be and get it to the right place and have it grow its axon, its wire, to exactly the right place. It is a general treatment that is basically giving the whole cell back and hoping it will reproduce and go to the right place and do the right function. So you can imagine it's a very complicated and difficult thing to do, and it may work more in places that don't have the exquisite necessary wiring. If you think of it as wiring that has to go to an exquisite place, as opposed to getting a mass of tissue to a piece of organ that just has to create a new muscle and contract, like in a heart. Unfortunately, the brain and the eyes and the optic nerve don't work that way. They have to work by wiring. So that's what stem cells do. Gene therapy works to insert the normal gene into either the genome in question or into another genome to make the protein that's missing because of an abnormal gene. So gene therapy is actually delivering genetic material, in this case, the only way we can is to the nucleus of cells. And in the case of Leber's gene therapy, we deliver it to the nucleus, but we put a little special sequence on that DNA which says, when you make that protein with an extra little something that tells that protein to go to the mitochondria where it's not being produced appropriately by mitochondrial DNA. Because as of yet, we still do not have a way of doing gene therapy that goes directly to mitochondrial DNA. So we have to use the fact that 90% of the proteins that are necessary for mitochondrial function are actually coded for in the nuclear DNA, and therefore the cells have a normal mechanism for getting proteins that are coded for in the nucleus to go into the mitochondria. So we basically piggyback on this natural alliance that nuclear DNA has with the mitochondria in order to overcome the fact that we have a mitochondrial DNA abnormality that's not making the correct protein right there in the mitochondria. So instead, we get that correct protein coded for in the nucleus and imported into the mitochondria, and that's called allotopic rescue. And that's what all the gene therapy trials for Leber's are currently based on.
Sorry, we're gonna.
So they're totally different things. Oh, but he did have a second question. The whole issue of when you go on .gov, this is very important, okay? Anybody can list any trial on NIH.gov. It has nothing to do with the FDA. These are not approved. And if you look at the bottom in small print, which is probably the problem for you guys, it says these are not validated in any way. It's just an overall listing, and that's why you will see some of these stem cells, so-called trials on there. They're not really even trials. They're just people injecting things in the eye and in the spinal fluid. Please be careful. This does not mean that they have been in any way validated, and what you need to do is make sure you talk to your doctor who knows how to look at this and tell you what really is a real trial and what is not. Thank you. Yes?
Wait.
So I came to see you in January of 2017 to try to get in the stealth trial, I think?
No, I don't do stealth.
Or Gensight,
yeah,
sorry.
Yeah.
And before that, I went to see Dr. Guy in Miami to try to get in his trial, and I was dismissed from both of those trials just for my visual acuity wasn't high enough. I'm in the Laris trial now, taking idebenone.
Yes.
I noticed that it was an exclusion criteria on several of the studies that are going on right now. Have you taken idebenone before? Do you see a point at which that may be removed from exclusion criteria because so many potential candidates have taken it
Right.
as an immediate recommendation?
Sure. So the Gensight trials don't exclude having taken idebenone before. You just can't have taken it within 1 week of entry, and then you can't take it again. That's where you may decide, if you are eligible for a gene therapy trial, you may decide that the idebenone is working for you, you don't want to give it up, and you may choose not to go into a gene therapy trial. The only trial that excludes people who have had idebenone before currently is the Leros trial itself. If you've taken idebenone before you enter into the Leros trial, which is an idebenone trial, then you're excluded.
Good afternoon, doctor. On my journey, so to speak, until I was finally diagnosed with Von based on the blood work, I took a blood test that showed that I had an autoimmune disease, as autoimmune retinopathy. You know, I tested positive for it. Now, whether or not that would be a false positive, obviously it was. First of all, have you encountered other patients over time that may have tested positive for an autoimmune retinopathy that have had levers? Number two, is there a way of educating ophthalmologists, neuro-ophthalmologists, whatever the case may be, that just because they test positive for one, not to rule out the other?
Well, I can't speak for every neuro-ophthalmologist, but I will try to answer your question. The whole field of autoimmune diseases is very difficult because your body, so what we're talking about is the immune system. So when your body's immune system sees something foreign or something it's not used to seeing, it will react with an antibody or attack that thing, that cell, that virus, that whatever. It is well known that if you damage tissue, in this case the retina per se, let's say the ganglion cells, you release antigens that are normally not exposed. You know, the cell changes and it shows a little something on its surface, which your immune system will then attack. So you don't know when you test positive with an antibody whether that's a primary antibody that's chewing up the cells, and therefore that is an autoimmune disease in which you have autoimmune antibodies that they tested and found positive, and therefore it's causative of the damage, or whether damage made your body normally and rightfully so mount these antibodies to this exposed new antigen that came from the primary damage. So it's a secondary measurement. And my guess is what they measured was this secondary effect that your body had to the primary damage from labors. Can I say with 100% that you don't have both? You know, the old Saturday Night Live thing, stop, you're both right, it's both a breath freshener and a floor polish? No, I can't. But my gut feeling is that's probably what it is, because I don't even know what antibody they found, and maybe it's, you know, they just found it, it's not like the usual primary one that pops up. Now, regarding your other question, I've devoted my life to make ophthalmologists and certainly neuro-ophthalmologists recognize this disorder as soon as possible. But you have to admit, especially in the United States, where we don't have many nuclear families very much, you know, everybody lives somewhere else. We don't have a socialized medicine where you have a registry of who goes blind, unlike in Australia and other places where they can really chart big families and pedigrees. A lot of our labors cases don't have a family history, even if maybe they do, but they just don't know about it. So you have a singleton person come in, and I guess the first flag should be they're male, because optic neuritis tends to involve females more than male. But they show up with one optic nerve disease, and in general, there are other more common things when you show up with an optic neuropathy than labors. To me, you know, there's an old saying, when you own a hammer, everything looks like a nail. Man, I can do it like that. I see labors where it doesn't exist because I'm always looking for it. But, you know, it's an education process. I do the main education courses at the American Academy of Neurology for the neurologists. I do the main education courses at the American Academy of Ophthalmology for the ophthalmologists. I read papers like crazy trying to make people aware. But sure, people, you know, doctors see a lot of patients these days, every day, and they go first for the common thing, and then it takes a while for the tiddlywink to tumble in, right?
My question, you see this a lot on the Facebook page, is when you hear from Gensight or any of the other trials that there's improvement. I think a lot of parents, when they don't understand, and I don't understand fully what one line, two line, whatever, you're hearing improvement and you're thinking 2020.
Yeah.
So my question is, you know, kind of in layman's terms, what are people seeing as improvement? I mean, slight, you know, I guess that's my question, because on the Facebook page you get that question a lot.
Yeah, and I think in a way you guys can answer that actually better than I can. What's meaningful to you? Is one line better on the eye chart meaningful to you? Is 2 lines better? Is more peripheral vision? Is better contrast sensitivity? Is and that's, you know, is it being able to walk around and not step on your dog, like, you know, the person from that company was saying. And it's very hard to get appropriate endpoints that actually have functional meaning. One of the best things that the other labor, remember, and you guys have probably all run into this, right? There's Theodore Labor was an ophthalmologist in the mid-1800s who described 7 different eye things. And he did Leber hereditary optic neuropathy. He also did something called Leber's congenital amaurosis. It's totally different, except that it was named by the same guy. And so, but that's a retinal degeneration, a retinal disease that these kids get that is, they're really, really visually impaired. And as you know, there's gene therapy for this disorder, LCA, Leber's congenital amaurosis. And the way they proved efficacy was by having the patients before treatment and after treatment do a visual maze, walk a maze. So it's a function, the end point of these trials was a functionally meaningful endpoint for those kids, which was, can they get across a room that looks like a kitchen without tripping over something? And I'm more and more, I think, in addition to biomarkers which will allow us to know which carriers are at risk and things, I think that these trials, I would have been delighted if we didn't need a statistician for these trials. I want the penicillin for Leber's. I want, within 10 patients, it's so obvious that we don't need people saying, well, maybe if we use contrast sensitivity charts instead of the regular chart, we see. Of course, I want that kind of result. But until we get that kind of result, we got to figure out what's a meaningful result for you all. So you tell me. Now I'm going to flip it back on the Facebook page. You tell me what is meaningful. You know, they asked Lissa that as the representative of you guys at a meeting I was just at, and she can't answer because she's not a patient. And I'm afraid for some of you it's going to be different than for others of you, and so it's going to be hard to come up with. But that's something that maybe you all can help us with. You know, what's going to change things? Does it have to get so much better that you can drive? Does it have to get so, or is it just enough to be able to use assistive technology a little better? You know, if you all can come up with better delineation of what's meaningful, then maybe we can change our endpoints in these trials to meet that.
Just a question going back to Dr. Katz's presentation from Gensight. He commented on the drug-treated eye responding as well as the sham-treated eye, and that seemed counterintuitive. My question is whether you can comment on if 97% who present in the first eye and then within a year in the second eye, is that so counterintuitive?
The question is whether you believe that having it happen in the first eye is what triggers the second eye, or whether there's just something about the retinal ganglion cells in the two eyes that reach a certain threshold around the same time with whatever triggers labors. Your question is excellent. I should have been from Missouri. You know what the license plate says in Missouri? Show me state. I'm the exact opposite of some of my colleagues. I need to be shown that something is true by evidence, rather than others who only will stop doing something if they're shown that it's not helpful. Does that make sense? And so I'm a fairly pessimistic person about that data, even though I'm a consultant for the company. I'm the international coordinating principal investigator of the trial, right? I want it to work. But I'm a bit skeptical that there really is a bilateral effect, and that we aren't just seeing something that's a little bit that we didn't understand of the natural history. I don't know is the question. I'm trying to keep an open mind, but the way you put it is a very good question. Maybe it is that one eye talks to the other eye when vision gets lost, and that's why the second eye is involved, and we just don't understand how that could happen. I do know from the trial that we did in the mid-2000s with bromonidine, and I think we even have one or two people who might have been involved in that, that when we looked, we included people who had one eye involved, and they still had to have 20/25 or better vision in the second eye. So we thought, whoa, we're getting in there before it ever happens. And we didn't stop it from happening, which may be just the drug was inefficacious. It just didn't work. Or, and then we went back and looked at the visual fields, it may be because on every one of those patients, there was a tiny little scotoma, a tiny little spot already on the visual field when they were still completely asymptomatic in that eye. So something already was starting, and maybe it was too late already. And that's what has me worried about this disease, because I'm for the gene therapy to work, it takes 4 weeks to be incorporated in the cells. And we're saying, well, just show up within a year and we'll give it to you. Maybe it's like stroke. Maybe we have to give it to you within a week. Like stroke, they have to do it within 4 hours, and now they have treatments that work. Maybe it's an emergency. I don't know that yet. I think the best thing is if we can find a marker to let us know who's going to lose vision before they do.
So we need to let Dr. Newman catch a flight. I have one person here with a question. I have one of my own, and I don't...
I'm good, as long as I leave by 10 up.
10 of?
10 of.
Okay, so then I'm going to ask the indulgence of people who were going to be on my panel. We're going to go real fast on the next part, because this is too good to let go.
Oh, no, it's okay.
Dr. Newman, I just had kind of an unrelated question, but since Ilhan is a mito disease, I have a lot of glaucoma in my family on the maternal side. Do you see any, like they just told me now that I've got glaucoma as well.
Yeah. There shouldn't be any relationship. Again, we don't know everything, but as far as we know, there is no relationship. They are both optic nerve diseases, though. And certainly one could imagine that if you already have a low reserve from one cause of an optic neuropathy, you may not do as well if you have another cause of optic neuropathy. But specifically genetically related, we don't believe so. Now, dominant optic atrophy, be careful, because that's often called glaucoma, and it really isn't glaucoma. They call it that because those patients have what are called cupping of their optic nerves. So that's a whole nother. Yeah. Okay, then you got glaucoma.
One question that comes up a lot is there was talk in the earlier session about in your talk about how smoke and binge drinking is something to be worried about or concerned about as a carrier. When someone's been affected, can they stop worrying about it?
Well, as a doctor and for general health, I would say absolutely not. And since we know that even the 1178 mutation has a small but definite chance of spontaneous recovery, and certainly the other two mutations, or at least the 14484, has a superb chance of spontaneous recovery, why would you risk that not happening by taking an obvious toxin of the optic nerve? But has anyone specifically looked at that? No, they have not.
So just a real quick question. For carriers or people who've been affected, have you heard of any non-vision related symptoms? For example, I've lost my sense of smell quite a while ago. And then the other thing I wanted to say real quick, I saw many people taking videos and pictures. If everyone could post that, that would be a huge help. Thank you.
So, you know, a long time ago, I coined the term LHON+. I'm not sure I did a great service doing that, because I'm not sure what's related and what's not related. But I'd flip the thing back on you and say what's astounding to me is if every cell in the body has every circle of mitochondrial DNA having the mutation, why aren't we seeing more abnormalities of everything? And so I can't tell you what's associated and what's not associated. There are some things that are more kind of mitochondrial-ish than others, like hearing loss, migraine, diabetes mellitus, peripheral neuropathy. I've not heard anosmia, smell, but I don't know. It's possible, and yet it's possible not.
You just mentioned LHON+. I always want to know what the chances of getting that is.
So again, it depends on how you define it. So there are minor abnormalities that people are going to have in the general population, and therefore you will have as part of a general population, and who knows whether it's actually related or not. There are, however, definite patients with the 11778 mutation most of the time, but the others as well, the 3460, who actually have abnormalities on their brain MRIs in areas that look like where we have mitochondrial things. Areas in the what's called the area postrema, areas around the fourth ventricle. And I think in those patients, it is likely that what we're finding and the symptoms they're having from those MRI findings are indeed related to their Leber's mutation. There are other mutations related to Leber's that give Leber-like vision loss and dystonia, for example, the 14459 mutation. I think the vast majority of folks who have Leber's hereditary optic neuropathy, 3 primary mutations, will only have optic neuropathy in their lifetime. And if they develop a peripheral neuropathy, or they develop a little of this or a little of that, that it's probably something they would have developed anyway, but I cannot say that for sure.
In your last talk, you talked about the triggers, and you brought up the drinking, and then you also brought up tobacco smoke. But is it just tobacco smoke? Because previously I've heard about bonfires and barbecues and everything else. And
so this is, yeah. So I think that anything that truly exposes you for repetitive use to things that are oxidizers, you know, so cigarette smoke causes free radicals. Free radicals are bad for your mitochondria. It goes for cigars, it goes for cigarettes, it goes for marijuana, unless it's only, you know, once in a while. It would go for probably fires and campfires and being a firefighter if you were in smoke every day or every week. it's not something that you would avoid every once in a while. I think that, and indeed, even the fire smoke thing comes from one case report of two twins, twins are two, one of whom was a firefighter and the other one who wasn't, and one got LHON and the other didn't. But if you look in the literature, 5 years later, the one who wasn't anywhere near a firefighter, he got LHON too. So, I think that basing changing your lifestyle terribly on one or two case reports is not the way to go. And I think the study on tobacco use, which included cigars, but it was mostly cigarettes, that study is good. The binge drinking part of that study only barely came out with it, but come on, who wants to be binge drinking? Don't do that. So I think it may be time for me to Vamanos, or, okay, well, go ahead, one more.
Okay, just one question. In your presentation, you said that the average age for onset for career, for the onset for male was between 20 and 50%. Why such a big range? I mean, between 20% and 50%, it's very different.
Yeah, and the same between 4% and 32% in women, because all I'm doing is quoting the studies. I'm just quoting that there are studies that have as low as that percentage and as high as that percentage. And I can't determine which of those studies are correct, and it may be different in different populations. So the lowest is actually the Australian study, which is very good because that's one of those countries where they can capture every single patient and every single family with labors because of the way their health system is arranged. So according to the Australian study, it's less frequency of females and males, so it's at the lower end of the expression.
Dr. Newman, thank you so much.